Now we are. And I'm going to hand it off to Rich.
Okay, well, thank you for that very kind introduction, Jessica, and I'm really delighted to be here tonight. The In addition to the local connection here, working with with NAMI, the I also want to embarrass Dr. Bellotta a bit because she's been a good friend and colleague for many years. And for those of you who aren't familiar with Dr. Bellotta, she brings really world-class expertise in psychiatric evaluations here in town. She also has provided me with free exposure therapy because I actually went to high school with one of her uncles. So she also has done free exposure therapy and helping me feel old as well. So. But it's great to be here. And just to introduce myself very quickly, and while I'm doing that, I'm going to bring up my slide presentation. And let's hope this goes well. So I'll share that and start the slideshow. And just a second here. Okay, so hopefully you can all see my slides. And I just got to do one more technical detail here. And something. Now, just a sec. I'm going to try something else here. I'm much better at treating OCD than I am at working with Zoom. So uh, normally, that's the button I wanted to push. There we go. Okay, I think we're good. And so just to introduce myself quickly, psychotherapy is actually my third career. When I went to college in the 1970s, when dinosaurs roamed the earth, I was one of Cornell University's first dual majors in engineering and psychology. And people joke that I grew up to build bridges that would talk people out of jumping off of them. Uh, in reality, I ended up doing both things at very different points in my career. So I was in the technology business for a long time in the software industry, eventually moved into management and managed the customer contact centers for large software companies in the software business. When that field became obsolete, I then became a writer and public speaker on customer service and specifically communication skills with customers and in the workplace. So I made most of my living getting up in front of large audiences, pointing at my glasses and inviting people to get angry at me. And that was a lot of fun. That went really well for me, and that helped bankroll in my 50s doing something that's always been a calling for me, which is becoming a psychotherapist and specializing in treating anxiety disorders. I have lived experience with anxiety disorders and OCD. Good therapy has dramatically changed my life, and it's the main reason why I'm a very happy and functional person nowadays. And uh, and it's really been a great joy to share that with other people and help them get well. And so the reason I'm really glad to be talking with you folks tonight, and also for those of you watching the recording, is this is a really exciting time to be in the OCD field. 30 years ago, we didn't know what to do with OCD. And until just a few years ago, there was really only one main treatment approach that worked a little more than half the time. Nowadays, especially thanks to the advocacy of therapists who have lived experience with OCD and emerging literature and emerging research from those communities, we now have a smorgasbord of good treatment strategies, and we're much closer to our goal of reaching everybody who suffers from OCD. And so, with that, I just want to start off by talking about what is OCD. For those of you who aren't familiar with it, I imagine some of you are very familiar with it in terms of loved ones or perhaps yourself. But first of all, it's a low prevalence disorder. So, in other words, it only occurs in about one out of every 40 or 50 people. We could compare that against, for example, social anxiety, which occurs in about 15% of people, fears and phobias, which are 5 to 10% of people. On the other hand, OCD is something that touches the lives of a lot of people. It's one of the top 10 causes of disability, according to the World Health Organization. Half of all cases are severe. And even though it's a low prevalence disorder, that's still a lot of people that we're talking about. If we took every person in Tompkins County with OCD and formed a company with them, it'd be the second largest employer here next to Cornell University. So it's characterized by obsessive thoughts and compulsive rituals. And I'll explain what I mean by that in just a sec. Um, and it's not the same as fears and phobias. Sometimes when people hear about OCD for the first time, they think, oh, everything's OCD. It's not, especially given the terminology. So let's say you've just broken up with your partner. You may feel that you're obsessed with that partner, or you're obsessed about that breakup. That's not obsessive compulsive disorder. If you break up with your partner and now suddenly you find you're having to clean the house 8 hours a day, That's obsessive compulsive disorder. That's something that's usually, it's to throw out a big term, it's ego dystonic, doesn't cause any pleasure. It's not something that you want to do. Um, Often it doesn't have a real story behind it. In fact, it often makes no sense whatsoever to who you are as a person or what's happening in your life. Although it often has themes that touch on things where you feel vulnerable. It's not a emotional disorder. We largely see it as a neurological disorder. So it's not really considered, the result of bad parenting or stress, although, of course, all of these things exacerbate any disorder like OCD. And most importantly, it requires a very different treatment approach compared to therapy in general, and also compared to other anxiety disorders. So some of the things that OCD is not. It's not being neat or picky. Um, in the community of people with lived experience with OCD, you should be aware that people are highly offended often when people use the term "I'm so OCD" about making sure my closet is straight or my house is clean or whatever, because this is a severe disorder that often consumes these people's lives. I'm not particularly offended by it, but that's a sensitivity you should be aware of with people. And again, it's not the same as a simple fear of or a phobia. To me, the differentiator is whether it has a story behind it. So, in other words, if you got really sick and now you're worried about germs, that's a phobia. Phobias are actually a lot easier to treat than OCD sometimes. Uh, and on the other hand, if somebody has contamination OCD, they're often spending their entire lives preoccupied about what might contaminate them, and they navigate their way through a crazy quilt of avoidances. Uh, and another thing that is, I think, really important in terms of reducing stigma for people is one very common form of OCD takes the form of intrusive thoughts, which often horrify people. If I switch to what types there are, in the second column here, we have sexual orientation OCD, where you're afraid that you have a different sexual orientation than you identify with. Pedophile OCD, where you worry that you're being attracted inappropriately to children. Or harm OCD, where you have intrusive thoughts that you might harm somebody. Uh, the difference between these intrusive thoughts and urges is huge. And if people understood that better, there'd be much less stigma about it. We all have crazy thoughts. I mean, how many people have picked up a baby and said, boy, if I dropped that baby, it would probably die? We all have crazy thoughts like that. When you have OCD, neurologically, those thoughts have a starkness and a reality that's very frightening to people. And so they often spend a lot of time, furtively doing research on Google to see if they're okay, constantly testing themselves to see if it's a problem. Um, and usually those thoughts are the opposite of who you are as a person as well. I have never in, almost 15 years of practice known anybody with an intrusive thought to ever have acted on any of those intrusive thoughts. And I highly doubt that people ever would. Let's take, for example, people who worry about, being a pedophile or sexually abusing people. I have worked with people who have, sexual. I have worked with people who are sexually deviant in ways, and I have worked with many people who have OCD. They couldn't be more different in terms of how they present themselves. And I would call it the Dunkin' Donuts analogy. So if you were to see me full on, you'd notice I'm somewhat overweight. And so if I'm at a Dunkin' Donuts, I don't worry that I want a donut. I don't wonder if I want a donut. There's this magnetic force pulling me towards those donuts. And people who are, truly sexual deviant, um, they're often seeking treatment too. They don't want to go to jail any more than any of us do. And the main thing that makes people offenders is not sexual desire, but impulse control as well. Uh, but on the other hand, they're attracted to, and there is an attraction. If you have a sexual orientation OCD, you're probably not fantasizing about, the sexual orientation that you're not. You're probably worried that you noticed how cute, that person of the same or a different gender was, and you're worried that that might be you, and you're trying to stop that. So I just wanted to clear up that difference. Some of the other common types of OCD. My favorite area and my specialty, which I'll be talking a lot about tonight, is contamination OCD, because it represents more than half the cases of OCD. In popular culture, if you look at shows like Monk, often people with OCD are presented as having contamination fears. I personally suffer from that theme myself, and my own recovery from it has had a big influence on some of the work that I've been doing in treatment strategies for it lately. There's also people who involve checking. For example, I had a friend, not a patient, a friend who suffered from checking OCD, who they lived 30 miles from work and they would drive to work in the morning and they'd be almost there and then wonder if they locked the door of their house, and they would drive all the way back home, make sure their door was locked. Usually it was, and then they'd come back late to work, for example. Then there's counting, where people have to count things around them, or things have to happen in lucky or unlucky numbers. There's scrupulosity, which are fear of, offending God, or, having blasphemous thoughts. And a particularly challenging form of OCD is hoarding, because almost all forms of OCD that I'm describing are what we call ego dystonic. They cause no pleasure, they just cause distress. Hoarding, people who hoard find value in what they hoard as well, which makes it sometimes a little challenging to treat, but that also is treatable. And just to wrap up this introduction to OCD, I want to share the official DSM-5 criteria for OCD. As you can see in this cartoon, I say I still got 37 minutes to go before it's OCD. And the criteria is obsessions and compulsions both have to take place. Those compulsions could be mental and not just physical. We don't tend to believe nowadays in what we call pure OCD, that are just obsessions. And the obsessions have to not focus on real problems in your life, as I was mentioning before. And the compulsions need to take up your time at least 1 hour a day and cause significant distress. And, many, if not most, sufferers realize that these obsessions and compulsions are unreasonable and unrealistic. Not everybody, though. Once in a while, we've all treated people who have what we call limited insight, where they believe those obsessions, where they believe that the world is dangerous out there, or they could get sick from touching a doorknob. And here's some quick examples of OCD, just to wrap up the introduction here. So in the case of contamination OCD, you've got somebody who obsesses about coming in contact with germs. It's a very common theme. Washes his hands more than 50 times a day. I've seen people who wash their hands more than 200 times a day and never feels clean enough. And so they're constantly preoccupied with this. Any of these OCD themes can grow to rule your life without treatment, and that's one thing I think is important to understand. Sandra's a new mother who has intrusive thoughts about harming her son that horrify her. She loves her baby, so that she doesn't have to be triggered by her fear that she might snap and hurt her baby. All the sharp objects in her house are locked away, and she incessantly seeks reassurance from online, on the internet, and from her husband. And those functional deficits are where we focus on in the treatment, as we'll talk about a little later. And then George checks compulsively, and he obsesses that his doors were unlocked or that the stove was on. And then he comes home to check the locks in the stove, and as a result, he's often late for work. So here's where I really want to focus our time tonight, is on what the current treatment strategies are for OCD. This would have been a really simple talk 5 years ago. There was really only one strategy, and that was exposure and response prevention. And that's been around for about 30 years at this point. It was a life-changing treatment compared to the days when we didn't know what to do with OCD. Sigmund Freud wrote off OCD as an incurable problem, for example. One person who's one of the national spokespeople for the OCD Foundation nowadays and has a PhD and runs a large treatment center, her parents were told that she would be institutionalized for the rest of her life when she first was diagnosed with obsessive compulsive disorder. Thanks to ERP, that changed for about 50 to 60% of people who suffer. We now have a couple of newer approaches that are really exciting. One is called inference-based therapy. That's a more cognitive approach. It's very well tolerated for people who aren't comfortable or too squeamish to do exposure. And it also works on the thought process behind OCD. So often it can get to the root of what's causing this tendency towards obsessions. And what's important about that is, unlike fears and phobias, like let's say you get bit by a spider and it hurts and you get sick and, from a poisonous spider, and now you have a fear of spiders and you're afraid to go places that have a spider. If there's no spiders in your life, there's no problem. On the other hand, OCD can easily shapeshift. because it's a survival instinct gone haywire. I like to think of it as a disorder of intelligence, because most people with OCD that I work with are highly intelligent, articulate, often professionally successful. And the I think a lot of this dates back to when we were cave people, when there just was a rustle in the bushes, and the cave person went, "Yeah, got eaten," and the person who worried about it survived. And so I look at OCD as a survival instinct that's kind of gone haywire a bit. And inference therapy is a cognitive approach that takes longer than ERP, but on the other hand, it dissects the logic process that leads to it. We'll talk about that. And then my favorite topic, which is what I'll call the mastery approach. This is work that I've published in the last couple of years on contamination OCD, because we've discovered that many contamination fears do not habituate. Disgust, for example, is processed in a different part of the brain than fear. And trying to do exposure therapy to get used to disgust is kind of like trying to get used to sitting on a hot car wearing an itchy sweater. If any of you folks listening tonight have ever eaten something when you were a kid and got really sick from it, I'll bet you anything you avoid that food today. And I'll also bet that if we tried to do exposure therapy and tried to make you eat that food and get used to it, I bet it wouldn't always be pretty. So the mastery approach is based more on adapting to functioning better as opposed to getting used to yucky things or uncomfortable thoughts. I'm not going to talk in any great detail about medication, and I'm not qualified to because I'm just a therapist and not a prescriber, but medication is also part of the equation for some people with OCD. I tend to have a cautious view on medications, but it's because, again, half of all cases are severe. Medications is often an important part of how people function better with the disorder. Okay, so any questions before I move forward with talking about some of these treatment strategies? One of the things that's nice about a nice small group is, folks are free to speak up anytime you want or not. Uh, so I'm going to jump in and talk about exposure and response prevention because this is where treatment for OCD really started. This is where the International OCD Foundation first took flight maybe 20 years ago. And this is the first step that really gave people a lot of hope uh, in treating OCD. It also has led to some cultural issues that I nowadays do a lot of advocacy to push back against, and I'll get to that in a sec. Um, but simplistically, the goal of exposure and response prevention is to do something you're afraid of in steps, in stages, not just ripping the Band-Aid off, and not to react with the rituals you do to make yourself feel better. And it's generally done weekly with a therapist. And with practice, you eventually learn to habituate or get used to these thoughts and triggers. And this is a phenomenon that we call the extinction burst. So when you do an exposure, when you choose to do something that you ordinarily wouldn't want to do because of your OCD, like you think something's contaminated and you touch it anyway, and then you sit with that feeling of contamination, you don't wash your hands, you don't do any compulsions, and you don't try to distract yourself from the thoughts. You sit there and be present with whatever you're feeling. Um, the magic that happens here is that fear is controlled by an almond-shaped gland in your brain called the amygdala. And the amygdala is a gland that triggers a short-term fight, flight, or freeze reaction to protect you from danger. Because it's a short-term response, it extinguishes more quickly than you might think. And so what happens is when you touch something contaminated and then don't wash your hands, if exposure therapy works, then what's going to happen is your anxiety is predictably going to go up. Um, so to me, the key of good ERP is you choose a step where you can tolerate that level of anxiety. I am not a big fan of, feel the fear and do it anyway. I'm a fan of taking gradual, measured steps where you build on your success. So what'll happen is your anxiety will go up, you sit with it, and then a couple hours later, ooh, it drops off a cliff. And often those create permanent neurological changes in your brain. If you ever see books out there with titles like, rewire your brain to not worry, or rewire your brain to not have anxious, it's a code phrase for exposure therapy. And I also want to say that exposure therapy has a huge PR problem, which is somewhat deserved. Some of you may have seen, for example, reality shows where they make people tearfully face their worst fears, and the where or they have people with contamination fear stand in filthy dumpsters with cat vomit in them and things like that. I will never treat a client that way. And that's one of the differences of having lived experience has in terms of how to approach this. What I like about exposure therapy is that when it works really quickly. So in other words, some of the other techniques that we'll talk about take time to change, some of the behaviors that we're talking about. But when you're doing exposure therapy and you hit that extinction burst, um, it's like a magic eraser for fears when it works well. And I think it's a very humane treatment approach if you make the steps small enough and if you choose the right steps. My ERP sessions have a lot of laughter and a lot of collaboration. I never push a client to do anything they're uncomfortable with doing. But I do encourage them to challenge themselves a little bit and see if they can push those boundaries out. Um, in 2018, I published a paper with the IOCDF where I changed the language I used with doing ERP. So instead of saying here, go out there and scare yourself, I said, start in your comfort zone, stay in your comfort zone, and see where you can take your comfort zone from week to week. See what you're ready to do today. And this idea of readiness is a core of what I now practice for contamination fears, as we'll talk about in a bit. Here's the problem I have with exposure therapy as it was practiced for many years, though, and this is something that the entire lived experience community has been pushing back on with some success just in the last 2 or 3 years. If you went to an OCD conference even like 3 or 4 years ago, it would be, ERP, 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 and ERP. It was the only flavor in the menu, and it was always presented as the only way to get well. It's kind of like going to a medical conference that was devoted to a drug that made some of us throw up. And and it led to an ERP culture, which has been a real problem because, as I mentioned before, every major OCD treatment technique works a little more than half the time. And there developed a culture where if you failed that, then what would happen is it was inherently blamed on the patient. It was you weren't working hard enough, you're not brave enough, you're not zen enough. And it created a mindset where recovery was only for the special brave people, and those who didn't recover, it was somehow some kind of character failing of theirs, which we are now learning through emerging literature is totally incorrect. So I love ERP. I've taught over 100 clinicians here in upstate New York how to do it humanely. It's one of the quickest and most effective ways to treat OCD when it works, uh, but it doesn't always work. So I want to move on to a couple of other techniques that we want to talk about tonight. The next is what's called inference-based cognitive behavioral therapy. This has been one of the greatest triumphs of the lived experience community. Inference-based therapy is a strategy that's been kicking around in the research world for almost 20 years at a very low level, and primarily the group in Canada at the Research University of Montreal. And so what happened just a few years ago was people in the lived experience community started meeting privately. We actually had, I was part of this group. We had a WhatsApp chat group, which we had on all the time. We'd compare notes about our own treatment experiences and discovered that we weren't alone in some of our own bad treatment experiences. And so we started having weekly teach-ins about this inference therapy technique, uh, helped develop training. We now have several of my colleagues now have firms that do training on inference therapy. And there's now a Facebook group with over 3,500 clinicians in it that are learning about this or practicing it. I've been trained in it, of course, and uh, I actually helped organize the first special interest group in the IOCDF for inference-based therapy. Um, so, what is inference therapy? Inference therapy, instead of taking a compulsion and bopping it on the head behaviorally, like we do with exposure therapy, what we do is we look at the logic that formed the intrusive thought that led you to do the compulsion. And I'll talk in a little more detail about this, but just to give a quick overview, uh, the those of you who are familiar with cognitive behavioral therapy, you may be familiar with its approach is to change the content of your thought. So, in other words, if I have a negative thought that I'm going to flunk this exam tomorrow, I'm going to try to reframe that as a realistic thought, saying, I may flunk it if I don't study, but if I study, I probably will pass it. And here's how much I need to study, and here's my game plan. Here's what I'm going to do. So we try to both change the content of those thoughts and move you up the spectrum from helplessness to agency, where your thoughts are now directed around a game plan for how to act, That's the behavioral part of cognitive behavioral therapy. We discovered over time cognitive behavioral therapy in its pure form does not really work with OCD, which is a neurological disorder, which is not a disorder of logic. Um, but it's or let me correct that. It's a disorder of the logic process. And so inference therapy works on the process by which you form those thoughts so that you can eventually recognize, say, I see what I'm doing here. That's now I can ignore that thought because I'm using an invalid process that I've figured out why it's invalid. I'll give you a personal example of it. Uh, one night many years ago, I was visiting my family in Arizona. I was at my hotel in Phoenix, and one night at the hotel, I just started feeling really depressed, and I thought to myself, what's going on here? I never get depressed. My family treats like anxiety all the way. And, what's wrong with me? Am I going to feel this way forever? What did I do here? And so then I took my temperature. Turned out I had a 100-degree fever. As soon as I looked at that thermometer, I was like, okay, got it. I'm sick. My depression vanished instantly because now I knew why I was feeling physically off the way I was and how I was misinterpreting those sensations as something they weren't. That's the way inference therapy works, is you do a lot of practice, not just with your own stories, but with other people's stories as well, where you drill and learn how obsessions are formed. And you learn how you form your obsessions, what your vulnerable self theme as to why you choose your obsessions, so that you can eventually go, aha, I see what's going on there. Uh, so the pros of it, it's fully cognitive, so there's no exposure required. That's a huge benefit of it because dropout and treatment refusal rates are huge with exposure therapy. And even when it works, nobody wakes up in the morning and say, "Oh boy, I just want to get used to yuck again today. How much fun!" So, and it also, because it works upstream on the logic process, it often addresses a lot of these root causes of OCD. And so, uh, outcome studies that have been done over the last few years have shown that inference therapy has roughly the same effectiveness as ERP. They've now done some random control trials with large samples and discovered that it too has about a 60% effective rate. The cons of it, and there are some serious cons with ICBT, which I hope actually evolve over time, is number one, it takes a long time. Inference therapy involves a 12-step, 20-session process where you drill all these various techniques for picking apart your logic. You're not going to see results until you're well down the road in practicing these things. So you're in therapy for a relatively long time before you start seeing results in your own life, often. And although that's not always the case, and it's not always effective. So if you're in one of those unlucky 40%, for example, then you can get to the end of this 20-week process and have it go, ha, this doesn't work for you. Uh, and these are all things that I think need to be addressed. I did a presentation for Cornell Health last year, and the first thing they said about inference therapy is, we don't have time to deliver it. The semester isn't long enough for us to go through a course of inference therapy. Plus, we only see students for a half hour once a week or once every 2 weeks. So ERP has evolved over time quite a bit. And I personally, as a bias, believe that inference therapy needs to evolve as well into an ICBT light, where it can be delivered quickly and the greatest hits can be taught quickly. Currently, its gurus feel that the amount of time that is invested is very important to the outcomes of it. So that's an ongoing debate in the field. So just quickly to give you an overview of ICBT, um, the the sequence for any form of treatment that people go through is a prompt, something triggers them. So, for example, they see something that makes them feel contaminated, or they touch something they wish they hadn't touched, or they are changing their kid's diaper and they worried that they touched their daughter's bottom and wondered what that means. So, what that leads to is an obsessional doubt. A doubt is not the same as the obsessive thought. It's not the same as the symptom. And in inference therapy, we spend a lot of time helping people tease out what the doubt is. So it's not just, I'm worried that I'm a pedophile. The doubt is, I'm the kind of person who, could harm somebody. I'm the kind of person who could be unreliable, who could snap. Um, that doubt leads to consequences, which is, you know, um, they feel really anxious about it, or they feel yucky, or They avoid things that they would otherwise not avoid. And so they make their partner change the baby all the time, for example. Um, and not giving in to those obsessive thoughts leads to anxiety, which then leads to the compulsion, which is like pouring gasoline on a fire and reinforces the response to the obsessive doubt. So ERP works down here in this last box. It takes the compulsion and bops it over the head with a behavioral intervention. And when it works really well. And it works quickly, which is why, I'm not giving up any technique for any other technique. ICBT, on the other hand, very well tolerated, very cognitive in nature, and but it works here in the second box of identifying that obsessive doubt, identifying your vulnerabilities to it, and learning how you create the logic. So the other thing I want to talk about is why OCD obsessive thoughts are so compelling to people, even when they make no sense to somebody. And part of the ICBT process is giving the OCD its day in court and looking at why it's perfectly logical for you to have those thoughts. So we're not criticizing OCD, we're not anthropomorphizing it as a bully. What we're doing is saying, hey, OCD, this makes sense to me. I can see why you're helping me think this way. So what we do is we break down these obsessive thoughts into where they might have come from in terms of facts. So let's say you have a contamination fear. A fact might be people do get sick from germs. Rules. The CDC says wash your hands for 20 seconds. And the more you wash your hands, the better. And they don't realize what OCD is about. Hearsay. Somebody, walked through a hallway and then suddenly they got really sick. So it must have been the hallway that caused it. So hallways must be dangerous. Or personal experience. You may have gotten sick from something. It may have seemed to have come out of the blue, and the uncontrollability and illogic of that makes everything seem scary. And then there's my favorite, which is it's possible. Um, One of the steps that's part of the inference therapy process is to help you imagine developing a fear that a meteor is going to hit you in the head if you walk out of the house. And people, when they put their heads to it, can come up with very convincing stories about why a meteor might, in fact, hit them on the head when they walk outside the house. Recently, in our group of clinicians that do inference therapy, somebody posted a picture of a news story from Australia where a meteor did, in fact, land in somebody's bedroom. So that family can't use inference therapy at the moment, or can't use inference therapy as it's currently taught. But for the rest of us, learning about how this logic works is a very big part of the process. To wrap this up, some of the other thoughts about some of the other strategies that are involved in inference therapy is we come up with the obsessional story. In other words, the narrative that your logic leads you to believe in terms of all the things that you avoid and all the things that you get triggered by. Another very important and time-consuming part of ICBT is finding out what your vulnerable self-theme is. In the ICBT world, it's a false view of the self that is always the opposite of who you really are. So often that vulnerable self-theme is I could be irresponsible. I could harm people. Uh, I could let my family down. I could not provide for people in the way I'd like to provide for them. And so then, armed with this knowledge, the later part of the process looks at uh, how OCD thoughts are always imaginary or irrelevant, even if they're theoretically possible. So we're essentially teaching people to know when those thoughts occur that you don't have to challenge them, you don't have to contest them. You can just say, "Oh, I know what you're up to. Never mind. Uh, I'm not going to pay any attention to you," and mean it and feel it. And that it takes time to get to that point, of course. And the penultimate concept of inference therapy is this idea that you're on a metaphorical bridge between the dissociative story that you've been telling yourself when you're trapped in your OCD versus reality in your senses. So, for example, you lock your door, you hear it go click. Um, and in the OCD world, it's like, well, what if I didn't do that perfectly? What if it popped out of the lock again? What if that? And so you learn eventually to treat those thoughts as irrelevant because they're not grounded in any kind of reality or senses. So the the core of ICBT is to teach people how to cross the bridge. On one side of the bridge is the dissociative story. On the other side of the bridge is reality in your senses, what you actually observe. If you see a spot on the ground that's red, Is it blood? Is it AIDS? No, it's ketchup. And, where you're letting your senses tell you whether you should be worrying about that or not. There, it that part can get tricky because number one, sometimes people can't cross the bridge, and I think ICBT still needs some work in that area. And number two, not everything has physical senses as well. Germs, for example, can't be seen. And so, when I teach or practice ICBT with clients, I try to replace the idea of your senses with common sense. What does common sense tell you about a situation? Okay, and so finally, I want to wrap up our overview treatment approaches with what I've been doing a lot of work on the last few years, which is what I call the mastery approach for treating contamination OCD. Um, this is the TMI part of the discussion. I would love to say that this technique sprang from years of academic research, but in reality, it came from a combination of my own lived experience and emerging literature. So I have suffered from contamination OCD myself for much of my adult life. Um, and again, I'm a big believer in ERP. When I first became a therapist, I discovered that ERP was almost like a magic eraser for other OCD themes of mine. My OCD actually started in response to trauma as scrupulosity, which is religious obsessions. And ERP worked beautifully for that. And those thoughts don't trouble me at all nowadays. But for most of my adult life, my own OCD has been fairly well managed, and I would liken it to a rock in my shoe. Until a few years ago, when I transitioned to retirement from my therapy practice, I was diagnosed with a heart condition, and I was put on a medication that over time plunged me into the worst depression of my life. And again, I'm somebody who's not prone to depression. And that sent my contamination fears totally through the roof. It took me almost a year to discover that my medication was the problem and get off the medication. At that point, my OCD was still eating me alive. And because I'm fairly well connected in the OCD profession, I sought out some of the rock stars of the field for therapy. And they were good therapists. They were doing what they were trained to do. But on the other hand, doing traditional ERP therapy with my contamination fears uh, traumatized me and left me housebound and sleeping 2 to 4 hours a night. So it was a raging dumpster fire for me. Thankfully, the story didn't end there. I thankfully hooked up with a clinician from here in the local area, ironically, Katrina Blomquist at the Mindwell Center, who was formerly a senior clinician at Cornell, who was a huge expert in ERP, but was willing to listen to what wasn't working for me. And we spent months literally jiggling the key in the lock, trying to find other strategies that I could use to climb out of the jungle. Because at this point, by the time I was seeing Katrina, I was literally spending my waking hours, shuttling back and forth between the two chairs in my house. It felt not contaminated enough to live in, and it was really no existence at all. So, so circling this around to the mastery approach is uh, we quickly gave up on the idea of trying to habituate to contamination itself because uh, what we found is that that didn't work for me. But more importantly, because I started looking at the literature for this, uh, what I discovered is that there's a wealth of emerging literature that shows that disgust-based fears, which is what I had and didn't realize, they're processed in a different part of the brain called the insula, and it goes into long-term memory. And its job is to keep you from getting poisoned, not to help you run away from an immediate danger that's frightening you. And so these are very stubborn triggers, and ERP often just makes things worse and causes cross-contamination, which is what happened in my treatment. All of these studies ended with the same conclusion, which is, golly, we need to study this more. And that was very frustrating for me because, of course, I wanted to get well. So where the heavens opened up for me was, and again, I'd love to say this was based on research, but it was a total accident. I had this big motorhome in my driveway, and it and if you know anything about motorhomes, what happens is they have to be winterized every year. And so what happened with us is over the summer, that motorhome got infested with yellow jackets in its air conditioner on the roof. And so we had a technician bravely come and bomb that air conditioner with cans and cans of insecticide, which of course is very triggering for me since I had contamination fears that were through the roof. And then the technician, flushed that out with water, not realizing that the yellow jackets had eaten through the ceiling and had flooded my whole RV with insecticide. And after that, I couldn't get near it for months. So now here it is, winter coming on. Recreational eels have cheap plastic piping, and you have to go in and drain the pipes and run chemicals through them, or else the pipes are going to burst and it basically ruins your RV. So I had to go in there. And so with Katrina's blessings, I did something that is normally a huge no-no in ERP, the biggest no-no, which is using safety behaviors instead of inducing anxiety and trying to get used to it, which I knew wasn't going to work. What I did was I put on some ratty clothes that I was never going to wear again, and this kind of a spacesuit of boots and gloves and masks, and went in there. It was horrible. It was like World War III. I hated every minute of it. I didn't habituate to anything, but I got the job done. But here's where the heavens opened up for me. Was a couple weeks later, I went back in there bravely to clean up from the winterization job, and I discovered something amazing. I was no more comfortable with insecticide than I ever was. But if I used the same safety behaviors, I discovered that I could go into the RV as much as I wanted to and feel safe. And so remember, I'm basically housebound at this point. So I started doing more of that. So I started going in the RV, cleaning it up, driving it around town, getting it repaired. Now suddenly I'm going shopping again, and getting out and doing things and going out of town. And so that escalated to a point where I recovered fairly quickly. And so a few months later, my wife and I decided to go to Arizona and move there for the winter, where I have a surviving family. And that was a great time. And then a few months after that, I went to Europe. I'm a Czech citizen, actually, by descent. And I went back to my homeland for the first time, had a fantastic time. So, my exposure consisted of here I am in Arizona hiking Sabino Canyon every day, eating quesadillas, going to baseball games. Here I am in Europe, eating, gnedliki in Prague. And so my exposure consisted of exposure to life. And an important point I want to make about it was that I wasn't trying to get used to my disgust fears. The biggest test of this strategy was my biggest fears are poisonous plants, especially oleanders, because it's the most poisonous plant in the United States. Consuming one leaf will kill a human being. Most people will say to themselves, all right, fine, I don't eat oleanders, so no problem. But for me, stepping on a leaf or brushing against a plant is like totally no bueno. Uh, so we moved to Arizona. We leased an apartment for 3 months, sight unseen, and it is surrounded by oleanders. It's like blood in an operating room. And so, but what but I never had a single bad day there. I enjoyed every minute of being in Arizona. And what was important was I took reasonable accommodations to avoid contact with the plants. So I'd watch where I parked. I'd watch other people park next to oleander bushes and wade through the oleanders and I'd say, nah, it's not me. Um, I didn't have guests over to our apartment because I knew that they'd be cavorting in the oleanders and I didn't want that inside my apartment. But by making a few reasonable accommodations, I had a great time. I was quite well as far as I'm concerned. I functioned really well. I was really happy. And so that was a watershed for me. So the capper on this is, again, I mentioned that reasonable accommodations are a mortal sin in exposure therapy. We discovered some emerging literature that judicious safety behaviors improve outcomes for OCD treatment. The late Stanley Rockman in Canada did a big study uh, with contamination sufferers showing that judicious safety behaviors helped improve recovery, which was my outcomes as well. Uh, Shannon Blakely and John Abramowitz, who was the editor of the Journal of Obsessive Compulsive Disorders back then, collaborated in a study where they used judicious safety behaviors for people with spider phobias and found it was at least as good as ERP. And so now that we have some literature support for this, and now that I was suddenly doing really well these days and functioning, happy and subclinical again, um, a year later, I decided to write up, what I'd experienced and some of this literature supporting it as a proposed treatment protocol for contamination OCD, and posted it in a big group of like 4,000 clinicians that treat OCD that I'm part of on Facebook. And it got polite applause, and people appreciate it. Fast forward a year and a half later, Chris Tronson, one of the two national spokespeople for the Obsessive Compulsive Foundation, posted in our group and said, hey, who's this Rich Gallagher guy? I found his blog and it cured me. And so the next thing I know, it was the lead clinical article in the IOCDF newsletter. I was on every podcast in the field. Chris and I just chaired a panel session at the national conference last fall that was one of the most attended sessions at the conference and drew almost 500 people. And so in the year or two since, Chris started championing this within the International OCD Foundation, this has been a watershed approach for humanely treating contamination OCD, and particularly things that don't habituate. Uh, I recently published the first ever workbook on contamination OCD, and before I wrap up, I'll give you guys a chance to get a copy for 99 cents if you're interested. Either way is fine if you want to make me 72 cents richer. Um, but the thing that's really important about this is, so this has now evolved to an approach where this is how I treat everybody with contamination OCD. And instead of trying to get used to yucky things, what we're trying to do is help them get lots of practice functioning better in ways they want to function better. And so your goal is to comfortably practice a lot so that these triggers soften over a long period of time and that you habituate to these situations, not necessarily to these triggers. So it's an exposure model, but not a habituation model. It borrows very heavily from another form of therapy that's known as ACT, or which is where you move towards your values rather than just try to get used to yucky things for its own sake. Um, the good things about it is it creates rapid functional gains in triggers that don't habituate, and it's helped a lot of people. I hear every week from people who've been left for dead by traditional exposure therapy, and who now suddenly are functioning a lot better, or suddenly see hope in terms of how to get treated. And it's based on exposure to life versus yuck. Um, it's nothing's perfect, including this approach. And as a disclaimer, I'm just one yacht in the middle of upstate New York. I'm not a research institute, so this still needs empirical research. And I welcome people studying this approach. I do have a case study paper. It's currently in final review with a major journal, where one of my patients went from severe to subclinical within just 7 sessions. And I'm hoping other people will study this. And I certainly welcome how this approach is going to modify and change over time. And it doesn't always work because there are some situations that get, that for which it stumbles. So quickly to compare this with the ERP approach that we'd used before, traditional ERP always involves a behavioral intervention where you induce anxiety and try to get used to that anxiety. So traditional ERP involves, contaminating everything so that there's no escape. In that big group I talked about on Facebook years ago, before my relapse or before I knew how we treated this disorder, I saw a post in there that could have made me cry. It was a young man who was autistic, and his therapist talked him into contaminating his last safe space, which was his bedroom. And so now it's a month later, and the kid still isn't sleeping. And the therapist is wondering, well, what do I do about this now? He's really suffering. And all the other therapists, because remember, this was the only club in our bag years ago, would come back and say, oh, he needs to do more work. He needs to do more exposure. He's not brave enough yet. Keep pushing. Now, with what we know now, that approach would be totally inappropriate for that. The focus of ERP, which again, I'm a big fan of when it works, uh, is to learn to tolerate distress and tolerate uncertainty. There was a watershed, podcast from the International OCD Foundation a couple of years ago, where one of the people who's really a leader in the lived experience community, Allegra Caston, she's going to have a major book coming out from HarperCollins on her life experiences in the next year or two, which I think is going to be very popular when it comes out. But she spoke up on behalf of the lived experience community and say, hey, having a treatment goal of learning to tolerate yuck, learning how to tolerate uncertainty, learning how to tolerate anxiety, that's a dull gray life. None of you would want that. And we need to do better. And I think she's 100% right. That's part of the reason that my own mastery approach really involves more fun, more ice cream, more intimacy, more life, and not just exposure. But the treatment revolves around habituation. It has an extensive research base, and there's been, at times kind of a culture war where they're saying, well, this is the biggest evidence-based approach. And the lived experience community has come back and said, but it doesn't work for everybody, and our suffering matters too, and it's not just our fault anymore. And so, and luckily, if you looked at the programs that we had at this last year's conference, it's really amazing how much our profession has opened the tent to new treatment strategies and new thinking about this. The book that I just wrote, the Contamination OCD Workbook, has been endorsed by many of the faculty of the International OCD Foundation, which of course was the home of a very rigid focus on ERP until very recently, and a lot of the major clinics have adapted it now as well. So with mastery, the goal is to spend more time in situations that you want to master and listen carefully to do it as comfortably as possible so that you get lots of practice doing more of what you want and functioning how you want to function. So this approach is generalized to where every day you try to push your boundaries out further in terms of how you function, but you do it either with gradual exposure for things that do habituate or with reasonable accommodations and safety behaviors for things that don't habituate. And in just a sec, I'll talk about what good versus bad safety behaviors are. I'll give you an analogy of how a mastery process might work. Let's say that you're a new mother and you're thoroughly disgusted by poop, but now you have your first baby, and who's, of course, a poop making machine. And this is just really hard for you. Traditional exposure therapy would be focused on helping you get used to contact with poop. If you read some of the early books on treating OCD, the book, for example, Stop Obsessing by Reed Wilson and Edna Foa, Edna was really one of the founders of ERP, literally suggests smearing some poop on your leg and getting used to it being there as a strategy. I will never do that with a client, but this is how we thought 20 years ago when these approaches were first coming out. Now, with a mastery approach, what I'd be doing is having the mother come up with a strategy that makes her feel safe changing her baby, like wearing gloves, for example, and changing her baby a lot. And I guarantee you that at the end of a month of changing your baby and doing it comfortably, changing your baby isn't going to seem as scary as it first did. The occasional errant bit of poop isn't going to seem as frightening. You may never love it. You may never get used to it. But that trigger will soften over a very long period of time. And now you're functioning as a mother the way you want to be functioning. Another corollary to this is veterinary care, which, veterinarians have described as being a flash flood of poop. New veterinarians often find that they are really disgusted by all the animal feces that get produced in the course of their business. And so paramedics who are getting used to dead bodies for the first time and accident victims and blood, they often find that all of them are sick to their stomach the first week on the job. But listen carefully. Paramedics don't roll around, don't go to funeral homes and hang out with dead bodies to get used to it. Garbage collectors don't roll around in garbage to get used to the garbage. They make reasonable accommodations. They go to work, they do their job. Those triggers soften over time, and in time they can pull back on the accommodations. And that's exactly the treatment strategy we use because it mirrors how human beings get used to disgust. So the key is to stay comfortable, do lots of practice, keep improving your functioning. And one of the things I like about the mastery approach is if you're making reasonable accommodations and now you're suddenly, leaving the house and doing things you weren't doing before, you're getting all the goodies up front of functioning better. Whereas with an exposure model, if you're just getting used to yuck, you have to get quite far down the road to get used to that yuck enough that you're going to go out and brave it in the real world. So it moves the benefits up front and then allows you to work at your own pace on pulling back on some of the safety behaviors that let you do that. And again, it has emerging literature support now that's starting to grow with time. So I'm going to walk you through just a couple of the key steps of the mastery process if I'm treating somebody. The first thing I'm going to do is help people set functional goals. So I'm going to ask them what their contamination triggers are. And then I'm going to ask, if you didn't have these contamination triggers, how would your life be different? We use a technique that's from solution-focused brief therapy called the miracle question, which is you go to bed tonight and a miracle happens and your OCD is gone. What would your life look like? What would you be doing that next day? And then we ask, now what would you most like to change? That's really important because back when habituation model OCD treatment was the rage, it was Dr. Wonderful who decided for you when you were well enough and what you had to face so that you were cured enough to function with whatever might come your way. Whereas this is totally patient driven. And to me, it's up to the client what they want to work on. I've had clients who had severe contamination fears and they, change out of their outside clothes and change into their inside clothes every day of their life, and they're fine with it, and their household is fine with it. So I'm not going to try to fix it. Uh, I mentioned being Czech, for example. When I'm in Prague, every Czech apartment, no matter how modest, has a foyer where you change out of your outside shoes and into your inside shoes. And no self-respecting Czech would ever wear outside shoes in an apartment. So my whole country has OCD. Uh, so I don't try to fix everything. We have the patience set the goals. What's important about this part of the process is I try to gently move them away from, I want to get over my contamination fears, because your goal isn't getting used to chemicals or poisonous plants or asbestos or whatever you're afraid of. Your goal is more ice cream, more intimacy, more ball games, more more of what you want in life. So we try to tease out what those functional goals are. Then the next and most important part of the process is creating a practice strategy. And this is where, when mastery fails, this is where it normally fails, because coming up with that practice strategy involves jiggling the key in the lock with people. Not every presenting contamination OCD case is as simple as putting on a pair of gloves or putting on old clothes. Um, Sometimes, cases where mastery hasn't worked involves you're living in somebody's house. You don't have the power to change anything. You don't have the power to use safety behaviors. You just feel trapped and stuck, and you can't afford to be elsewhere at the moment. Sometimes we have to throw up our hands and say, okay, this isn't the right approach for you, and this isn't working. But in cases where we can, this method lives or dies on finding ways to comfortably practice more of what you're doing. And I'll give you another example of this. Let's say that you are afraid of pesticides and you will not leave your house because your neighbors spray their lawn with pesticides. And so you never go anywhere. So my practice strategy might be visit your friends down the block and find a way to comfortably get to where you can visit those friends. So your strategy might be um, you wear a pair of outside shoes that you change into while you're going to visit your friends. You walk in the middle of the street, assuming it's a quiet residential street, and you're watching for traffic so that you're not getting near anybody's lawn. Now suddenly you're seeing your friends every day. And again, you keep doing that for a month, and now you can start to pull back gradually on these safety behaviors because you're functioning the way you weren't functioning before, and you're doing it comfortably. And so the key to mastery is what I call readiness, which is, and I think this is part of a general culture change that we're starting to see in OCD treatment in general, which is rather than challenging yourself to get used to something yucky, what I'm going to ask people to do every day is do what they feel ready for that day. And when they feel ready for it, in other words, they choose a step that they think is going to work, that feels right for them at this point. It may sound like a free pass to do nothing, but in practice, since most people who seek treatment really want to get better, I find that people find very creative ways to find ways to function better every day. And so this could involve taking small steps, especially for things that habituate, um, doing gradual exposure for things that do habituate, or again, using reasonable accommodations. So my question is always, if you had to do something you avoid, or you really wanted to do it, what would you do to make this possible? And the mastery approach makes it possible to look at more things than just exposure. You can look at things like, okay, if I went with a person I feel safe with, I could do this. If I'm a sexual abuse survivor and I'm socially isolated because I'm afraid of people touching me, uh, maybe I could try going on platonic dates and set reasonable boundaries with those people. So I'm connecting with people again and getting the fellowship and intimacy that I've been missing for so long. Uh, so it opens up a world of client-directed practice strategies. And the other big point is this business of good or bad safety behaviors. When I mentioned wearing outside shoes, when I first published this, a lot of people went, because, those kind of behaviors, it was believed, turned into compulsions. That the highway to hell is paved with doing things to protect yourself from the things you're afraid of instead of habituating to them. But what some of this emerging literature has shown that judicious safety behaviors, where number one, they help you function better, not just avoid things, and number two, they're reasonable and they exist in the service of helping you function better. So the idea of the outside shoes, for example, that's only a compulsion if it becomes an additional constraint on your life for what you already do. Whereas if you're using those shoes to help you visit your friends every day, and now you're not stuck in the house anymore, then that's a positive thing. That's what some of Rockman and Blakey's research showed us as well. It functions just like a crutch, where if you've broken your leg, a crutch lets you walk without hurting yourself or being in tremendous pain, and it's a temporary measure that you can pull back on over time as you heal. Uh, so a good example of a good safety behavior is, let's say your kitchen feels contaminated with insecticide, and you do what I did with the RV, which is wear ratty clothes and gloves and make delicious food in that kitchen every night. Um, Again, that's going to move you towards feeling better. On the other hand, a bad safety behavior moves you towards avoidance. So if you decide to call Uber Eats every night so you can be more comfortable and have food delivered to you so you never have to go in that kitchen, that's a bad safety behavior. I would never endorse that as a clinician. And that's really the core of what the exposure crowd is learning that they should have been worried about when they made safety behaviors a no-no for people. And they should also be reasonable. So if you're afraid to go to the grocery store, for example, bring a pair of food service gloves in your pocket and using them if you need to while you're handling the groceries. I think that's absolutely fine if it helps you shop at the grocery store every week. On the other hand, if you have to wear a hazmat suit every time you're at the grocery store and everyone's pointing at you, that's a little extreme. That's not terribly reasonable and not necessarily helpful. So part of it is a good clinician helping clients understand what good versus bad safety behaviors are. So I want to wrap up this section tonight by focusing on this idea of readiness, because I think this is something that applies to all forms of therapy. And it's been part of the cultural evolution of OCD treatment. So 20 years ago, when ERP was all the rage, uh, the main buzz phrase was bravery. And bravery was the idea that you do something you're afraid of, you induce anxiety, often a fairly high level of anxiety, like 40% out of 100. And then you seek that extinction burst and habituate to it. And for people who worked, that was wonderful. And it gave a lot of people their lives back. Over time, especially given the high dropout rate and relapse rate of exposure therapy, in the 2010s, this evolved to another buzz phrase, which we'll call willingness. Uh, we had a watershed presentation at the 2018 OCD conference. I was there at it, and it was an integration of ERP, exposure therapy, with ACT, acceptance and commitment therapy, which pivots around teaching people to understand their values and take steps to move towards their values. So the key of willingness is that with willingness, you, instead of just saying, I'm going to get used to yuck so I can somehow strengthen myself to prepare myself for whatever might come my way, um, instead, I'm going to choose things that really matter to me and that they matter so much to me that it's worth going through the distress uh, of the exposure. So what could possibly be wrong with that model? Well, for one thing, not everything habituates. So you're still torturing yourself, you're still cross-contaminating things, and you're not getting any better. And secondly, willingness can fail when your bravery gets ahead of what you're ready to do. So I'll give you an example of readiness versus willingness on my next slide. So the key about readiness is it's client directed. You do things that you feel ready for and that you believe will be successful. A great analogy I would give for readiness is if you've ever seen Nick Wallenda, the tightrope walker. A few years ago, he walked across Niagara Falls on a tightrope in front of millions of people on television. Was he scared about that? No. The reason he wasn't, he claims, was because for months, he practiced on a wire that was just a few feet off the ground. He practiced with, fans and water cannons that would simulate rain and wind and all the conditions that he'd be under. He trained himself physically that if he slipped and fell, he could grab onto the wire for up to 20 minutes if he needed to. He had a rescue team that could be out there in 90 seconds to get him if I needed. And he wore a harness that would keep him from falling to his death. So when he went on that rope and walked across Niagara Falls, he wasn't scared. He wasn't feeling the fear and doing it anyway. He wasn't habituating to distress. He was ready. And he did what he was ready for after lots of practice. And that's precisely the strategy that we use in the mastery approach. So I've treated quite a few people now with the mastery approach and had very good outcomes. But of course, I'm going to keep their stories private between player and coach. So I'm going to use a personal example of readiness. So take a look at this picture. Now, what is that toilet bowl sitting in the middle of the shower. A few months ago, I was asking myself that very question because I had the flooring replaced in my bathroom, and the workers who came in my ensuite bathroom at my house, my wife and I, they took our 30-year-old toilet and plopped it in the shower I use every night. Remember, I have contamination OCD. So that was for me, that was ugh. So how did I get used to it? I didn't get upset. I didn't panic. I used my treatment approach on it, and it worked really well. So every night I asked, what was I ready for that night? And I would take the next step that I felt ready for. So that first night, I asked myself, okay, if I clean out the shower and then shower in it and go to bed, will I feel clean enough? And the answer was a solid no. Just like if somebody smeared poop all over your shower. So I was not ready for it. So that night I took a sponge bath and went to bed. Uh, and we also have a second bathroom in our house if I needed it with a shower as well. So the next night I cleaned the shower. Bear in mind, it still doesn't feel clean enough to me yet for me to actually just stand in it. And then I went out and bought a shower mat. And that night I took a shower in my shower, make it a point to just stand on the shower mat. So it's like balancing on a surfboard. But I showered comfortably. I slept comfortably. The next 2 or 3 nights, I'd lather, rinse, and repeat, literally and figuratively, in that shower. So by the time it's 3 days later, now if my foot slips off the mat and I'm stepping in the shower, it's not a big deal to me at this point. Why? Did I induce distress? No. Did I habituate to anxiety? No. Did I tolerate uncertainty? No. What I did is I spent lots of comfortable time in my shower as I was ready to do it. And so now after about a week and a half or so, my shower felt fine. And I got there totally because I spent lots of quality time in my shower. And what's important about this in general is that this approach is not only well tolerated, but it also takes away a lot of the stigma. People find that they're functioning better quickly. And of course, we're not shaming or pathologizing people as they go through treatment. And if people come to me and say, "Hey, Rich, I didn't do any exposure this week," I applaud their good judgment, and then we strategize next steps. And every single client I've treated with the mastery approach has told me when they shook my hands and terminated therapy that losing the shame of their OCD symptoms was more than half of their recovery. And that was true for me as well, especially as a therapist who was still struggling with evidence-based treatment when I had my relapse as well. And so that's the thing I cherish the most about this. So again, this is very early work at this point. Still more research needs to be done on it. Having really good outcomes. I did a workshop for one of the nation's largest treatment facilities a couple of weeks ago, and one of their clinicians just got back to me and said, and this is a quote, "My jaw's on the floor at how one of my severe patients is suddenly functioning better and doing things that she couldn't do." And so that's the kind of outcomes that's really why I do this nowadays. Okay, finally, to wrap up, I'm not going to talk a lot about medication because it's not my expertise, but I did want to say that if you or a loved one is suffering from OCD, medication is part of the matrix for, I'd say, probably half the people I treat with OCD. For someone like me who's treated maybe 1,000 people in my practice over time, I'd say a quarter of them, and I'm one of them, couldn't hack the side effects of those medications at all. These medications often cause anxiety. They're stimulating, and they're hard to get used to for some people. Some people are very sensitive to those kind of medications. And so that's not a good fit for them if they can be avoided. Or if they're really needed because you're not functioning at all, and medication's one of the quicker ways out, people sometimes will titrate their way up from very low doses to get used to this. The vast majority of these medications are SSRI antidepressants. I recommend, if possible, you work with a knowledgeable prescriber who understands OCD because the dosages are often different from what is used for depression, and the side effect profiles are often different for people. Um, and incidentally, I have a great resource now for people who need an OCD prescriber. I just had a teleconference yesterday with Dr. Weston Ferrer, who's based in the Bay Area of California. He was a professor at University of California at San Francisco. He has just started a private practice dedicated to doing psychiatry for OCD sufferers. He's licensed in New York. He's actively looking for patients. And so if anybody among you folks are touched by OCD and need a competent prescriber, of course, I can refer you as well. Some of the indicators for whether medication makes sense is whether it's hard to function at all, what your attitude is towards medication. And I make it a point to really listen to how clients feel about whether they want to be on medication or not, and whether you have a prescriber who really knows where they're getting it. There's some really exciting work going on in terms of physical treatments for OCD. TMS, transcranial magnetic stimulation, it's had very good outcomes for depression. There have now been some studies where a deeper variant of TMS, RTMS, I believe they call it, has been used successfully to treat OCD in people. And sometimes intensive short courses of TMS have been helpful as well. The Rodriguez lab at Stanford and other people have been doing interesting work on low doses of psychedelics like ketamine or psilocybin for that. Again, some people can tolerate that sense of dissociation that comes with psychedelics. Other people are very frightened by it. For me personally, and this being Ithaca and a little left of center, I have a very cautious view of it because I see a lot of people going, ooh, psychedelics, how cool. But again, looking at my caseload of patients, every single client that I've ever had that's tried recreational psychedelics has described it as a complete disaster for them, where it's been like a grinding panic attack that lasts all day. Uh, so, be cautious and, and get good advice before, you consider some of these studies as well. There's also some medications that target glutamate receptors. N-acetylcysteine, which is a supplement that you can buy at Green Star, for example, uh, had some promise for some people. They've been doing studies at Yale on it, and it's shown that the evidence base for it is fairly thin. It doesn't work for a lot of people, but for those people it works for, it's worked for it. It's also been a very effective treatment for many people who have trichotillomania, which is compulsive hair pulling as well. So finally, I want to wrap up tonight by talking about what resources are out there in the local area and nationally if you need to get competent treatment for OCD. A few years ago, it was a really simple answer. If you were in upstate New York and you wanted to get treated for OCD, you had to see me. I was the only IOCDF provider in all of central New York, in all of upstate New York practically, who'd been through the International OCD Foundation's intensive training program for treating OCD. And when I was in regular practice, I was full with people hanging out the windows, and people would literally drive here every week from Rochester, Binghamton, Syracuse, Auburn to get treatment. That's changed dramatically, thankfully. We have great resources. The Mindwell Center, again, Katrina Blomquist, my own previous therapist, is one of the senior clinicians there. That's a cognitive behavioral therapy centric clinic, and they have great OCD expertise on their staff for cases that need it. Whole wellness counseling is a fairly recent practice run by Dr. Katie Durant, who was head of the program committee for the Ethica Therapist Group. She has also a multi-specialist, multi-city clinic that's primarily based here in Ithaca. That's another good option for them. And also, Dr. Caitlin Lilithal has started a outpatient therapy practice as part of the Cuga Health Network. And so they're not designed for high acuity cases, but Dr. Lilithal has openings. And if you're in the Cuga Health Network, then they also accept insurance. The Mindwell Center accepts Aetna insurance. I'm not sure about whole wellness counseling. For many years, out-of-network coverage has been kind of the norm for OCD treatment. In terms of local therapists, we now have a number of people who have really good expertise in exposure and response prevention and other techniques. Betsy Strayhorn is, she and I are the only two clinicians based in the Ithaca area. Betsy's actually moved to Beacon, New York to be near her daughter, but she still serves the Ithaca area through telehealth. Betsy and I are the only two clinicians here who have been formally trained by the International OCD Foundation as well. Adam Krantweiss, who's another psych evaluator, he has ERP expertise. Matt Dortona, a very dear friend of mine, lovely guy, super nice guy. He's always been a hardcore CBT therapist and works with a lot of OCD cases. Amelia Sauter, I don't know her well, but I see her popping up in our chat groups, online or in our Facebook groups online. And she has a lot of expertise in treating OCD as well. In the area, because now thanks to telehealth, you've got all of New York State open to you for New York licensed clinicians. A truly world-class facility in OCD is the Genesee Valley Psychology Center in Rochester. And that's run by Dr. Lauren Wadsworth. She is a protege of Dr. Jeff Szymanski, who was the executive director of the OCD Foundation forever until he went into private practice years ago, or a couple of years ago. Uh, Genesee Valley is a very LGBT-friendly practice. Lauren herself is quite a spokesperson for, what she calls justice-based care and LGBT-affirming care in the whole profession at conferences. And they they have a huge staff of clinicians up there in Rochester, and as a consequence of the fact that they take most insurances and they have tremendous outreach to the community, they also unfortunately have a long waiting list. So Lauren also recently started an out-of-network practice designed to get people in quickly called Meridian Psychology Practice, also based in Rochester. And a hidden gem you should be aware of is the Binghamton Anxiety Clinic. Binghamton University has a CBT-based PhD program in clinical psychology, and they have a general outpatient clinic, and they have a graduate training clinic. This is a separate clinic that's devoted to OCD and social anxiety. It's for PhD students who are specialized in that. Dr. Meredith Coles, who runs that, does a lot of research on OCD and things like sleep disorders. And so, thing about the Binghamton Anxiety Clinic is it's a really low cost clinic. Last I looked years ago, uh, they don't take insurance, but it's a sliding scale. It starts at $15 a session. The availability can be a little squirrely depending on what time of the school year, but you're being treated by PhD students under clinical supervision, which I think is a great deal normally. And it's a very low cost OCD specific training or teaching facility that's very rare in this part of upstate New York. And so they're online at anxiety.binghamton.edu. And there's also some good national resources if you're looking for people to get help out of state uh, or in general in the area. The International OCD Foundation lists people who identify as OCD specialists. It also identifies people like me who've been through their intensive clinical training as well. And they're also a resource for clinics, hospitals, and support groups as well. The Anxiety and Depression Association of America is another organization that is primarily CBT based and a good resource of people who identify as cognitive behavioral therapists, many, if not most of whom have OCD expertise. And then finally, the Academy of Cognitive Therapy, which was founded by the founder of CBT, Aaron Beck. They have very strict criteria for joining this academy as well. You have to have years of practice, you have to have demonstrated clinical expertise, you have to have read a zillion books. So these people are very hardcore CBT therapists. Matt Dortona is a member of the academy, for example. And then finally, I'll put a little asterisk in front of this. There's a smartphone app called NOCD. It originally started as a logging and tracking app for people to do exposure practice, but they've evolved over time where now they're a portal for online therapy. And they've been very aggressive in terms of having relatively low cost, often insurance, credentialed OCD specialists available very quickly on demand. And you can summon them through an app. Um, it's run by Dr. Patrick McGrath, who's been a very prolific author and speaker at OCD conferences. They've been very aggressive about expanding their footprint here and overseas as well. Uh, my only caution about NOCD is they run a manualized ERP treatment protocol. So they're not going to do ICBT, they're not going to do Mastery, they're not going to do ACT probably. So if you're one of the lucky 60% that exposure therapy works for, this is a great resource. And they've done tremendous inroads in terms of having access to care available for people with OCD. So finally, the last thing is going to give you guys the opportunity to make me 72 cents richer, which is the Kindle edition of my new contamination OCD workbook which is based on the mastery approach and takes a very deep dive on treatment planning and self-help steps. Is available online in the Kindle edition for 99 cents starting tonight for the next few days. So if you're interested in taking a deeper dive into this, go ahead and just go on Amazon and help yourself to a copy for 99 cents. Just make sure you order it today or tomorrow during its front list period. This has been a really popular book. This is currently the number 14 book in OCD currently. It launched when it first came out a couple months ago as the number one new release in OCD, and it's selling really, really well. So And there's surprisingly, even though this is half of all OCD cases, there has never been a uh, there's never been a workbook on contamination OCD. So finally, before we wrap up tonight, are there any questions that you folks would like to ask me? And again, since I have lived and clinical experience, feel free to ask me anything.
Okay, I've got a question.
Surely,
I always have a question.
absolutely.
So the entire program's been about OCD, but then we drop in the word anxiety. Can you have OCD without anxiety? Obviously, you can have anxiety without OCD. So,
I think the answer to that is yes, especially as we're learning more about disgust, for example. With my contamination triggers, the principal response was revulsion and there's a core fear associated with it, which is a fear that I won't sleep if I feel too gross and can't ever get to sleep, which was a fear that came true sometimes. When I went through traditional exposure therapy for my disgust-based OCD, what I would find is I would purposely contaminate myself with things and predictably, 2 hours later, my anxiety would go down, but my revulsion would not. And so some people feel spiritually contaminated by things and so forth. Um, so I think it's important to look at OCD as a neurological problem that's not necessarily just a product of anxiety. So that's a great question.
thank you.
Okay, anybody else? I know it's a small, intimate group tonight, so if I've stunned all you into silence, that's totally fine. But certainly welcome anything else that you folks want to ask about. Yes, Sandra. Sandra, you're muted.
I
There you
pressed
go.
unmute. It just didn't work the first 4 times I pressed it. We're currently working with a family. It's two sisters, and they both have severe autism, and one of them has severe OCD. And it's kind of a crisis situation at this point.
Sure.
We don't have a lot to offer except for support and continuing to refer them to different resources. So I'm wondering if you have any experience with those two things combined and if you'd be interested in being one of our resources for them.
The I'll give you nuanced answers to both of those things. Neurodiversity is a huge issue with OCD treatment and it has been for years because people who are neurodiverse often flood in response to exposure. And so traditional exposure therapy hasn't worked very well for it. And so, an approach like the mastery approach might be useful in a case like that. Um, the other problem that you run into is, again, when people are in crisis. When I have treated people on the autism spectrum, one of the things that I have found is that when they're in crisis, my lack of experience in high acuity situations has been a problem for them because, people who are autistic think on a different plane. In one case, for example, when I had an autistic client who was in crisis, I bought this thick book on cognitive behavioral therapy with people on the autism spectrum. And basically, what the book said is, you'll help them restructure their thoughts. You'll help them try to behave differently. They won't believe you, but then magic will happen, and then they'll eventually do it. And it's okay. That's somehow I never found the magic. So to answer your question about could I be a resource, I can certainly consult with clinicians. I can certainly be an adjunct therapist at a limited basis. I do not have high acuity experience, which means I don't know when to pull a trigger when someone needs a higher level of care. If somebody's in crisis, all I can do is call an ambulance and wave as the ambulance goes by. So within my fairly limited realm of expertise, yes, I'm happy to talk to you about that.
Great, thank you.
I want to throw out one other quick thing, Sandra, also that I had dinner in Phoenix this winter with Brittany Goff, who's an expert on. She is on the autism spectrum herself, and she's published some really incredible work on OCD treatment and the autism spectrum. She's licensed in Maryland and probably Virginia as well. So she may not be able to treat your clients, but she would be a good referral source. And
What was that name again?
Brittany, spelled like you would expect Brittany, Goff, Goff. And her practice is called Zen Psychological Center. So you might contact Brittany, let her know that I sent you her way, and see if she has any referral resources.
Rich, I've got a question. I do a lot with the NAMI helpline.
Uh-huh.
So let's imagine I get a phone call and somebody says, my loved one is obsessing.
Yeah.
Maybe they have self-diagnosed or had shared with me they're obsessive compulsive person, and they're in a deep, I guess, repetition in a crisis state about it. What is the risk? Is there any uh, suicidal self-harm description that goes with that? What would you advise in general terms as to like the softest way into trying to support your loved one because you don't want them to be rejecting you? But like what I
Oh,
don't know,
that's
little sound bites or whatever, because I don't want to be extreme in a response. I don't want to over us, but I also want to empower the person to feel like they have a place to go or a way to deal, a direction to go or a way to lean into it. But I don't know what that would be.
that is a wonderful, wonderful question, Lisa, and there's so much to say about that. Just to throw a few thoughts out in no particular order. Sadly, OCD does carry a higher risk of suicide. People who have OCD have, as I mentioned earlier, half of all cases are severe, and I've seen studies that show that people with OCD have roughly 10 times the risk of suicide compared to the natural, which may sound like a lot. We're still talking about a very small percentage of OCD sufferers, but that risk is very real. So yes, you should always assess for safety. That's one of the reasons I personally am very cautious about taking on high acuity cases, for example, because I don't want to do more harm than good with people. And so, uh, in terms of, I feel strongly that and I do a lot of advocacy around this nowadays in the profession. The single biggest ingredient in recovery from OCD is hope. That, unfortunately, the ERP remember, I'm a fan of ERP, and I'm a fan of the wonderful people who've helped get us to where we're at in OCD treatment. I don't have any enemies in this field. But on the other hand, the ERP culture often, you know, often created an ethos where there was only one way to get well, and if you're not brave enough or strong enough to it, you were left for dead. And so that's been changing. So, here in the local area, I don't mind at all if you contact me for possible referrals, for people who, Lauren Wadsworth in Rochester, for example, is a wonderful human being. I know she would never shame people with OCD. Uh, and, and I know people, among my crimies that I'm comfortable referring them to and so forth. For higher level of care, this is something that I also wanted to touch on. So when somebody's behavior is extreme and they really need, residential treatment or an intensive outpatient program or something like that, unfortunately, the vast majority of inpatient OCD facilities uh, still take a rigid view that we only do, evidence-based therapies that have been proven by lots of random control trials. I'm just a yock in upstate New York, so they're not going to do mastery yet, but even though it's making inroads. The one exception to this is the OCD Institute of Texas in Houston, run by Dr. Elizabeth McInville. Elizabeth was the woman who was, as a teenager, featured on Dr. Phil as the worst case of OCD ever, and and how she was forced into ERP treatment. She, over time, with her lived experience, now she has a PhD and she's a therapist and runs this big clinic, and they're one of the more premier inpatient facilities. I did a workshop for them a couple of weeks ago, and they're very open to new approaches and they're very humane, and a lot of their therapists have lived experience. And so I would highly recommend the OCD Institute of Texas as opposed compared to, whereas I've heard mixed reviews of a lot of the classic uh, treatment facilities, for inpatient treatment for OCD. They work for about 60% of people, where they can help them get at least kind of sort of well. And the sensitivity to neurodiversity is an issue too, and that's something you really have to screen for when you're seeking care for them as well. Back on my list real quick, because this is such an important question. Of the people I mentioned, I suspect everybody here is sensitive to neurodiversity, but in terms of expertise, a multi-specialist clinic like the Mindwell Center or, Whole Wellness would be a good place to start to see if they have that expertise. I would stay far away from Psychology Today's listings because everybody checks off, yes, I treat OCD, and no, they don't. If you want a good laugh, go look on Psychology Today for who treats OCD uh, in Ithaca, because you probably know a lot of these therapists, and you'll realize, no, they don't. um, and of course, ring me up anytime if I can help with referrals. And if somebody's not high acuity, I might even be able to help personally. So,
Yeah. Well, and in the personal sense as well, is there anything in the peer support and recovery
oh yeah,
movement for OCD?
the International OCD Foundation lists a range of support groups, and here again, I'd be happy to do some legwork because some people nationally have online support groups. For example, there is an official OCD support group, and that's on groups.io. I do not recommend them, frankly, because they are rigid ERP proponents that are not very open uh, to other models. So I'm not sure how sensitive to be to neurodiversity, or
Hmm.
and their ethos is kind of like, suck it up, you can do it. And
Hmm.
it's not always the best thing for a neurodiverse person who's on their last nerve. Um, but there are, and again, I might be able to help. I see a lot of these promoted in these private online therapy groups that I'm part of, so I may be able to, do some legwork on those. There was only one, no, I take that back too, in-person uh, OCD support groups in New York. One was in Utica, the other's in Rochester. And I can provide a connection with the Rochester group. It's small, uh,
Hmm.
and it's a little rah-rah as well. Uh,
Hmm.
so, so back to answer your question about peer support, though, if you're doing an intake with people like that, or if you're counseling people like that as a peer, I think it's important to keep pounding the message that you know, give them as much agency as possible in terms of, let them know that there are treatment choices. Let them know that this isn't their fault, of course, and
Hmm.
also, but the hope is important, that we know
Right.
more now than we did even 3 years ago on how to treat this disorder. And we're learning more about how neurodiversity affects OCD treatment. So, uh,
Hmm.
you know, that's the other main thing. Let
Yeah.
them know there's resources out there.
Yeah. Yeah.
I hope that's not too much
That's my
of an answer.
no, no, but my big takeaway is to give them hope and that there's opportunity and hopefully now we can develop some resource documentation, or maybe we already do, and I'm just not aware of it. So that when people do call us, whether it's a loved one or a person looking for support, we have material to, I can speak it and share the
Absolutely.
material and the resources, because the key word I heard you say was hope. And we're not allowed to give direct referrals to any particular places.
Oh, I
So,
understand. Okay,
so
absolutely.
I'm not doing like an intake. I'm having a conversation with an individual who
I understand.
would
Absolutely.
let's say call and say, um, my person, can't go to work because they won't leave the bathroom or their bedroom because of
Of
whatever,
course.
and they haven't, come out for food or whatever it is. And to be able to just find the hope and the optimism and a resource to that's an actual light of something.
I
So
want to say a
maybe,
couple. Oh, go ahead. I'm
yeah,
sorry.
no, you're perfect. Go.
I want to say a couple things here that's very important. I normalize everything, first of all. When somebody calls me up and says I'm stuck in the bathroom, the first thing I'm going to say is I see that all the time. And you're not hopeless or incurable. Uh, this is and the fact that it's affecting you severely doesn't mean that you're not going to get well. When I have to bow out as a treatment provider because of my lack of high acute experience, the first thing I'll say to people is, "You're not hopeless or incurable. You don't want a therapist who doesn't know when to pull a trigger for a higher level of care or know what to do when you're in crisis." And I'll help you find that as well. But I normalize everything, and I just want to say personally, a big part of the reason I do so much advocacy in the profession nowadays is you know, I don't want to bash the ERP therapists I saw because they were behaving how they were trained, but sadly, a lot of us in the lived experience community have, had treatment experiences where our hope was taken away because we were struggling with
Mm,
ERP. I had a situation once where, I once talked to my therapist and said, "Hey, look, I'm really struggling with this. Could we put OCD on the shelf for a couple weeks and talk about grief and life change and everything else?" He literally shouted at me that I needed to do more exposure and needed medication. And so I felt like jumping off a bridge. And so I try really hard to advocate, on my blogs in the clinical community to never talk to patients that way. Uh,
Mhm.
so sometimes so feel free to use me as a resource because I know what people, are empathetic to sufferers and give people hope. I also know some people that should be avoided, that have platforms in this field as well. So, and about having a resource to direct people to, if I can be of any assistance in helping you write that, feel free to, dial me in on that.
Very good. Thank you.
Okay, great. Okay, these are great, great questions. Anything else before we wrap up for tonight? And I realize I'm keeping you guys over a little bit, so my apologies. Okay, well, it's been delightful to be here with you tonight, and I really appreciate it. And I also want to thank you for one more thing to do. Tomorrow's the official launch for my workbook, and tomorrow I'm going to be doing a Zoom, session speaking to 500 people. So you guys have done a good job of helping me dip my toe in the water and get used to my stage fright. So thank you for that. And so with that, Jessica or whoever, Sandra, are you now running the show?
I came back. I had a little chaos. I had to walk off screen for a
Oh,
minute.
sure, that's fine. Absolutely.
Rich, thank you so much.
My
You
pleasure.
shared just a wealth of knowledge and resources for everyone who came tonight. And I know I have emails in my inbox of people who are looking forward to being able to watch the video on this. And I'm
Great.
just so grateful that you made the time to present and share your journey with us and what you're doing in the field with us. It's really important work. And I'm grateful that you could make the time to be here with us.
Well, thank you. And I really appreciate the opportunity to be with you folks tonight. So thanks again.
Thank you.
Okay.
Thank you.
Bye.